Understanding and addressing value, from the front lines to leadership, is essential to improve outcomes, enhance the patient experience, and reduce cost. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Senior Writer with AHA. Brought to you by the American Hospital Association's The Value Initiative and Physician Alliance, the Value Rounds podcast series, Working Towards Value Together, features leaders from the field to explore how clinicians and hospital leaders must work together to address healthcare value and affordability. Joining us today for part 2 of this podcast series is Elisa Arespacochaga, Vice President of Physician Alliance at the AHA, in conversation with Dr. Chris Moriates, Assistant Dean for Healthcare Value, Dell Medical Center and Executive Director at Cost of Care, and Dr. Pamela Johnson, Vice President of Care Transformation at Johns Hopkins Health System. Elisa?
Well, welcome, Chris and Pam. To get us started, why don't you tell us each a little bit about who you are and your role at your organization. Pam, let's start with you and tell us a little bit about yourself.
Thank you, Elisa. Thank you for inviting me today. I am a radiologist at Johns Hopkins, where I serve as the Vice President of Care Transformation for the health system, which is essentially the work to refine care, to improve outcomes and lower costs for patients. And I'm also the founder and director of the High Value Practice Academic Alliance, which is a consortium of about 100 academic centers working together to improve healthcare value.
And Chris, why don't you tell us a little bit about yourself?
Yeah, thanks. It's great to have the opportunity to be here and chat with both of you. I wish we could do it in person. I am Chris Moriates. I am a practicing hospital medicine physician. And also Assistant Dean for Healthcare Value and an Associate Chair at Dell Medical School at the University of Texas in Austin. And in those roles, I really work on the educational side of the house and how we teach and engage health professionals in improving value. And we'll talk a bit about that today, I suspect. And then also bridge into the into the hospital and how we implement that into the clinical setting and the clinical learning environment. And then I also am executive director of a nonprofit called Cost of Care, which has been around for about 11 years. And we really function to curate insights from the front lines about how we can meaningfully decrease the cost of care for individual patients. You know, we are really looking at affordability and envisioning a world in which no one has to choose between their life and their life savings.
Thanks so much. And as evidenced by the work that you do, you're both clinicians who are focused on how to bring value to patients. So I'm really excited to get into this conversation. We know hospitals and the clinicians who work in those hospitals are really working constantly towards improving value. And Pam, I believe you covered it, and so did you, Chris. AHA really looks at value as being defined broadly as those strategies that lower cost, improve outcomes, and enhance the patient experience. And I see that obviously in a lot of the work you do, but Pam, let's start with you. Can you talk a little bit about how you view value in all of the roles that you have, from founding the High Value Practice Academic Alliance to your work at Hopkins?
Certainly. So I think Chris and I both share a very patient-centered definition of value. We're concerned about patient outcomes, patient experience, and cost of care to patients. And so that's our broad definition, or at least my broad definition of value. And the work that we do is designed to improve the entire gamut of the medical experience for the patient. I think that we've shifted towards work that reduced overuse or improved appropriate use, and we're looking at a much more holistic view now as we've been working on this for a number of years, where we really want to advance evidence-based care so we improve outcomes. And in doing that, patients will be protected from unnecessary tests and treatments. But the overarching goal is to improve the health of patients and improve their outcomes and protect them from very expensive elements of care like emergency department visits and hospitalizations. So we've sort of grown our definition and our missions in the years that we've been doing this. And one of the great things about working in the High Value Alliance and with people like Chris is that the clinicians are very mission driven and very patient centered, and they're just wonderful people to work with.
I would agree.
Yeah.
Chris, what's your view on how value is seen through your work?
Yeah, I agree with Pam. You know, as I've reflected on kind of the last decade or so with this current movement around improving value, I've said it really started with awareness, just people being more aware of the physical and financial harms of overuse, of the cost being such a prominent issue for individual patients, and that quickly moved towards appropriateness. So you see the Choosing Wisely campaign become a national and now international phenomenon and movement, and hospitalists like myself and the large cadre of clinicians that Pam has assembled and led over the last many years have really addressed cutting out waste and cutting out things that don't make people healthier. And that is a really important and necessary step. But as Pam said, I think it's important that value doesn't get conflated only with waste reduction or only with out-of-pocket costs. It really has now moved to be about how do we provide the best outcomes for our patients, the best care at the lowest cost, and ensure individual affordability, not just cutting out waste, which leads to savings in total cost of care, potentially, at the health system level, but also ensuring that we're doing things that deflate medical bills for individual patients and that improve their outcomes. And, I think we've increasingly become more sophisticated in thinking about how to do that and what things are likely to reach the bottom line for patients themselves.
Absolutely. And building on those comments, from your perspective, what do you think is going to change in how value is going to be seen by patients in this post-COVID world? What do you think is going to change about how they want to engage in healthcare in their future? Chris, what do you think?
Yeah, I've been thinking about that, talking to friends and colleagues about this, and the way I'm seeing it is we have a real opportunity right now. I think obviously we've got a lot of the public's ear at the moment. We have actually generated a lot of trust with them, I think, as they see physicians and nurses and respiratory therapists and folks on the front lines. And what I think perhaps has been shocking, and not just for the public, but for me too, is that here in the most expensive healthcare system in the world, they are seeing us put on trash bags for PPE and, not having the masks we need. And I don't know if there's a more stark illustration of where the money is not going where it needs to be, right? We're not prepared to provide the care we need, and yet we're spending all this money on other healthcare. And so I think we have an opportunity to help people understand that, at least a third of what we're spending on healthcare is going towards care that's not making people healthier, and that money can be clearly used elsewhere to provide better public health, to provide to provide better resources for healthcare that helps. And so I think folks are paying attention to that, and if we have an opportunity to get that message right, we also have an opportunity to totally erode that trust that we've generated and an appreciation if we don't get it right, and if we go back into, return to normal. Everybody sort of wants to return to normal, but I think in healthcare, returning to quote unquote normal would be a terrible outcome here because we have an opportunity to do it much better. And so I suspect that folks are going to look at us to come out of this crisis with a better healthcare system, one that really is much more focused on outcomes. And, you asked about how will they change and how they want to engage in healthcare. I think once people see that they can get a lot of the healthcare they need via telehealth, via apps, via messaging, I feel like there's no turning back from a lot of that. And so we really are going to question what is reasonable and what's not, and what is high value. So I'm optimistic that we saw rapid reforms in response to COVID, some of them very helpful around helping spread telehealth and around, getting rid of some ridiculous regulations around how we provide care. And I think that we have an opportunity to advance that, and patients are going to expect us to.
Pam, from your perspective.
Well, I think Chris really did an excellent job answering that question. I can't really improve much on it by elucidating the fact that we have rebuilt the trust that was being eroded by all of the reports of cost, debilitating patients' finances, and many of us working very hard to try to demonstrate accountability, but in the face of massive numbers of dollars being wasted. And so it's almost like we've completely, in some ways, we've cleared the slate. We've demonstrated to patients that their well-being is even more important than our safety in some situations, and that they can trust us. But as Chris says, we need to rebuild in a new way. And we also have to take into account the patient's fear of coming to the health system, because it's something that I've witnessed a lot in the radiology work that I've been doing through the COVID pandemic. There are still patients in the ambulatory setting who need imaging, and while all of the much of medicine shifted to telemedicine, radiology continued to operate because the patients would have to come in for the imaging, and they're afraid of contracting the virus, and it's going to be several years before we have vaccines and it's under control. And we just need to find ways to reassure them that the health systems are not only protecting them, when they're in the emergency room or when they're in the hospital, but we're protecting them in the ambulatory setting, and that we're very much aware of their fears, but we don't want them to avoid care because of fear. They were previously avoiding care because of cost. And I don't think that, and now I'm worried that could potentially be confounded. So it's something that we need to think about in our redesign plans.
I agree, Pam. There's some evidence I've seen and people have written a bit about that actually cost is still driving a lot of the avoidance, even more than fear, which seems surprising. But people still are, primarily concerned about the bills that they will encounter if they access healthcare. And like I said, I think there's lots of ways that we could do this right, but there's lots of ways we could do this wrong. I think, I've already seen messages about how people have, not accessed healthcare, and how we don't need all that healthcare. Like, in other words, we've decreased our output by so much, and do people need it? And I think it's way too early to say that. This was a blunt instrument. There's a lot of people who are going to, I think, suffer bad outcomes by avoiding necessary care. And so I do think we need to be more nuanced about, and the we meaning like the general, public and medical profession, about the messaging around what is helpful, and what is high value essentially, and going to improve outcomes, and what's not. And not just go out there and say, yeah, see, told you need less healthcare, because that is not going to lead to the outcomes we want to see. So I agree completely with you.
Yeah, and also, I mean, taking into consideration the financial challenges that people who are not working are facing. So I completely understand why, if they're still concerned about the cost, why? Because it's even more problematic now. People have been laid off and furloughed, exactly. And So it's now even, it's definitely multifactorial.
Exactly. Yeah. People that thanks for drawing that line, because I didn't say that explicitly, which is people are more concerned about cost right now than ever because many of them are out of work, not sure about their employment-based health insurance status. Many of them don't have that. And so that's why the financial implications are potentially even more scary than contracting a potentially deadly virus, it just says so much, I think, about our current situation in this country.
Well, or even when they have the virus, there was a news report of a patient that was in the hospital, and after about a week or so, he said to his wife, I need to get out of here because we can't afford this. I mean, that's... Yeah.
I mean, we've heard heartbreaking stories about people about to get intubated, and that's their concern on their lips is who's going to pay for this, which is, it's impossible to even comprehend.
Absolutely. I'm going to diverge a little from some of the questions we had discussed, but one of the things that occurs to me as you're talking is that some of the care that remain very concerned that there are folks who are delaying care for fear of going into healthcare systems and being exposed, and that we need to also rethink how we deliver care. So the once a year, 15-minute checkup visit no longer is going to be the norm. And I think throughout COVID, we've seen a change in the way that we've tried to mitigate how we address those folks who have chronic conditions who couldn't just stop and delay care. What do you think are some of the things that you can be pulling from experiences that you've been able to see throughout COVID that will help sort of rethink some of those care models and maybe get at, maybe we don't need less care, we just need different care? And Pam, I'll start with you.
Yeah, absolutely. I think it's an opportunity to do something that we've needed to do for a long time, which is to harmonize care across the continuum. And there have already been efforts in place to bolster ambulatory care so that we can keep patients healthy. And potentially with the access that we have from telemedicine, that's sort of the first step in the right direction, where we can deliver care more frequently without the patients fearing the risk of coming to the health system. So other things that we can do that can improve health in the ambulatory setting are important, like remote monitoring after patients are discharged, or any kind of more careful monitoring of their health conditions, so we keep them healthy after they've left the hospital. And I'm hoping that as we ramp back up again, we take advantage of the opportunity to integrate these resources into practice more efficiently than we would have in the past. I think change has been slow, but now that people have gone through a very rapid change, it is an opportunity for us to rebuild it in a better way, as Chris has said.
Yeah, I agree. I think there's a number of examples. I mean, one that the telemedicine, as we've talked about a lot, but it's just been such a prominent and rapid change. But it is important that we focus on, as you said, Elisa, thinking about how you redesign that care. So our chair of medicine, Mike Pignoni, was very clear early on. Look, we're not just switching these to telemedicine visits to sort of tread water, to not, advance care or to just kind of have it as a stopgap. It really is that we're going to have to deliver care in that model. And we also need to recognize that not all care can we deliver that way. So we also need to be thoughtful about which patients do need to be seen and which need to be brought in. And so I think we really are starting to confront that on a larger scale than we have in the past. And within the hospital, it's interesting. I mean, stuff that we've certainly talked about and cared about for a while, such as communication, such as making sure that we have good counseling and remote monitoring for when patients get discharged, and we're thinking about the effects after they leave. We were able to turn on very quickly, and we realized, especially in the setting of not being able to have visitors in the hospital, and many of our patients with COVID, it turns out, have been primarily Spanish speaking, and there's been all of these communication issues. We were able to rethink how we use medical students. We had medical students who could call in from home and could then take on responsibility for updating families. We have implemented, iPads so patients can FaceTime with their families. We've ensured we're providing daily clinical updates for people since they're not able to come see their loved ones in person. And all these things that we should be doing all along just got pushed to the forefront. And it will be really important, I think, as we start to kind of reach a new level, a new status quo, that we think about which of these changes we need to now hardwire and sustain. Because I think it'll be really easy for people to just rebound back. And so we need to move from rapid adoption to sustainability.
Absolutely. I think that's going to be key, is really determining what are those things that were changes that are for the good, that bring value to the care system, to the patients, to the outcomes, and how do we hardwire them. So clinical leaders obviously are driving a lot of the value conversation, between the High Value Practice Academic Alliance conference that had over 400 folks spend a weekend in Baltimore last fall and for the third or fourth year in a row, to many of the conversations that you drive through costs of care. This conversation is continuing. What are some of the ways that clinicians in their own institutions can start connecting the conversations they're having with the work that is being done sort of at the delivery system level and at the payment reform, care model reform? So building on our previous question, how can we make those connections? Pam, let's go ahead and start with you.
Well, I'm in Maryland, so I feel like I have an unfair advantage in that regard. Because of our reimbursement model, we work, we have the same, we're aligned with the mission of the state with the total cost of care model, and it's been a driving force to empower the clinicians who are interested in this kind of change and escalate our work to the leadership level, including, for example, becoming vice president of care transformation. It's very important to our health system and our state and our doctors and our patients. And so if there are ways across the country where we can align the policies and the payers regulations with what the clinicians are trying to accomplish, we're all interested in the same thing, and that is delivering high quality care that improves outcomes without waste. And yet I think traditionally we have not had great alignment. We need to have systematic, concerted efforts for us to sit down and align the work we're doing, because otherwise, like Chris says, we have a lot of regulations that take time in the course of the day, documenting this, documenting that, when we really want to just be working. We're legitimately invested in achieving, the highest caliber care and refining the waste, but there are impediments when we have these regulations. So hoping that we can have more opportunities like that experience that I had, where we can all work together.
I think that's the key, Pam, is really recognizing that we all have a role to play, and that this is a problem that needs to be addressed at many different levels. So without getting too abstract, there's an analogy I've often used over the years that I probably, like many things, picked up from Neil Shaw, I'm sure, at some point. But it's that if you think about this as similar to the environmentalism movement or the green movement over the last many decades, there's lots of facets and roles that everybody has to play, and part of that is recognizing that policy and politics drive a lot of this, and so we have to be educated and we have to advocate for policies that help. And I think similarly, physicians need to be educated and they need to advocate for reforms and policies that assist in our overall goal. But there's also a role for individuals to play, and so we've changed our behaviors, we've changed our culture around this. We've created a kind of 360-degree accountability around littering. If you were to litter, people will not just, look strangely at you, they'll probably like tackle you at this point, at least in Austin. And so, and we've thought about our electrical usage and our water usage, and we've created feedback mechanisms for this. And so I think similarly, there is a role to be played by individual clinicians at the bedside, really starting to think about, am I providing care? Am I ordering an MRI that is unnecessary, and what are the effects of that? Am I, how do I fit in my own individual behaviors? But then also advocating and being aware of the issues around reform. And so I think there are kind of both levels. And what worries me sometimes is when I speak to folks and they see this as 100%, oh, well, that's a health policy issue, or that like it's somebody else's job or problem. Or conversely, 100%, like this is going to be solved by those of us at the bedside, just, making daily decisions. It really is a both end. And I think that is the way that we've been, and both our organizations have been trying to address this.
Well, let's wrap up with a couple of words of advice. If you had, just the equivalent of an elevator ride to give some advice to your colleagues about how to both think about and communicate with others about value in healthcare and how to really start that conversation about changing the culture, where would you start, Chris?
Yeah, I mean, I think we touched on so much of it today. I would just reiterate that we need to be clear, value is not about cheap healthcare. It's not about rogue rationing at the bedside. Value is about providing the best care at the lowest cost, and that is about being a good physician and a good clinician, a good nurse, a good pharmacist, a good respiratory therapist. That is what we all went into healthcare to do, and we can't lose sight of that. This is about professionalism. It's about being a good clinician who takes care of our patients and what they care about, the outcomes that matter most to them. And the outcomes that matter most to them is, what we need to prioritize. And that does include, by the way, their out-of-pocket costs. And so we should consider that as well. So I think we need to remain that this is patient-centered, that this is about professionalism, and this is just about good medicine, and not anything else.
Yeah, I agree 100%. It's really that excellence in medicine has a new definition almost, in that we want to protect patients, we want to give high quality care, but we need to protect them from financial burden. And it's as a radiologist, I'm sure this sort of sounds, maybe it's not unexpected from a radiologist because we don't directly work with patients, but we just all have to be cognizant of our patients' experience, and not just their financial cost, but the personal cost of care if it's not precision practice. And so the goal is precision practice with an understanding that it's really out of compassion for the patient that they have the best experience and the best outcome.
Amen.
Well, amen to that. Yeah. Thank you both. I think that last line really will stick with me. The idea that really one of the most valuable things you can bring to the table as clinicians is your compassion, and always keeping the patient in front of you. So I want to thank you both for just being compassionate physicians who always make me learn something new every time I talk to you.
And we thank you for your partnership and support.
Yeah, absolutely. Thank you.